Well, good evening, everybody. This is Conversations with the National Council of Asian Pacific Islander Physicians. We launched this webinar just a couple months ago, and we were really greeted with a lot of good compliments with regards to putting this webinar together. We're very pleased today to have our second in the series of Conversations with NCAPIP, and our topic is organized medicine addressing racism as a public health issue. Why is it important and what needs to be done? And we have some very honored guests as panelists and conversationists around this topic. I do want to remind everybody that's on this audience that this webinar will be recorded, and you also have the chance to chat and pose questions to the panelists. Hopefully we'll have some time at the end of the 45 minutes to entertain some questions that come from your audience. So now I will turn it over to Mr. Ignatius Bao, who will be the moderator for our session today around racism as a public health issue and the opportunity for organized medicine to address this.
Great. Thank you, Dr. Wong, and welcome to everybody to this conversation. We really want to make it a conversation with our guests and with all of you. So as Dr. Wong said, please both introduce yourselves in the chat and also gives us comments and questions as we go along. We're really pleased to have, in addition to Dr. Wong from the National Council of Asian Pacific Islander Physicians, Dr. Aletha Maybank, who is the Chief Health Equity Officer and Group Vice President at the American Medical Association, and Dr. Peter Bretan, who is the current President of the California Medical Association. So we have a national and state leader with us to really have this conversation around racism and how organized medicine can respond to that. So I'm going to start with Dr. Maybank. If you could just tell us a little bit about why you became a physician, what your early work was, and then you did a lot of work on health equity at the New York Department of Health and Mental Hygiene before you got to the AMA. So just tell us a little bit about that journey.
Sure. Well, one, thanks for having me, Dr. Wong. It's been a pleasure working with you over the last year and since I've started this role, and a pleasure, Dr. Bretan and Dr. Bao, also to be in your company and to be on this panel. I first, want to just center, and I think this is an important part of doing equity work, is center the experiences and lives of people who have been marginalized and who have been harmed as a result of racism in this country. And one, the indigenous people and the land that we rest on, and they're thriving and surviving to this day. Two, the Africans who were brought to this nation and forced to this nation for the sake of free labor, and many doors are opened for me because of all that sacrifice. And then more recently, just honoring, recognizing the 8 people whose lives were taken in Atlanta. And I think it's just really critical that we always center those voices and those lives, because it is why we do the work that we do and why I do the work that I do. And so, I've always, wanted to be a physician since the time I was 4 years old, as some people know the story. And my mother gave me the Fisher-Price doctor kit back then. And ever since then, I wanted to be a doctor. And I've had just fortunate and amazing opportunities. I'm a pediatrician by training. I was very, disenfranchised and turned off by the medical community after I finished residency, not because for the sake of the children and medicine itself, but the environment and the culture. To me was very oppressive and dismissive. I was very confused why, when my patients would come and they had all these social challenges, I was told, oh, don't worry about those, the social worker will take care of that. And it just didn't make sense to me in terms of the context of being able to care for a patient. And so, the medical kind of culture just wasn't really set up for that in terms of values as well as even practice. And so I went into preventive medicine, public health, had amazing opportunities to start an office of minority health from scratch, and then ended up in the New York City Department of Health to start a Center for Health Equity from scratch as well, under the leadership of Dr. Bassett. And it's really, through that work, and I would say both of them, I've had this opportunity to start things from scratch, but also in the inside of an organization. I'm a believer in when we talk about organized medicine, that yes, we need to organize for change on the outside of our institutions, but we have to organize for change on the inside of our institutions. And it's an and approach, it's not an or approach. And so the work that I lead up is really about doing that. How are we changing culture? How are we changing practice inside of the AMA so that we're able to do the external work that's actually advancing equity and employing anti-racism praxis and strategies. So, that's how I've ended up here in this space. I think, I seem to have some expertise in this work. We do need more people and more physicians that can actually do this work. That is one of the things that I'm really noticing during this time. So creating pipelines to have more physicians that can fight justice on the inside of organizations is really critical.
Great, and we'll come back to some of the past of the AMA and some of the more recent work that I think has been really groundbreaking in terms of what you're doing. So let me turn to Dr. Bretan, and you're a urologist, have been active in local medical societies before you took your current position as the president of the CMA. So talk a little bit about your journey as a physician, why you became a physician, how as a urologist you've become such a leader in organized medicine.
Yeah, I'm Peter Bretan, and I'm a transplant surgeon as well as a urologic surgeon. As the president of the California Medical Association, I am the elected voice of more than 55,000 physicians in California. So let me share with you my experiences, how I got here. When I was 8, I was told that my father was hopelessly dying, much too sick to undergo standard surgery. And I remember vividly and desperately asking a UCLA surgeon at the VA hospital to try anything. And I tugged on his shoulder. And he looked at me and he decided he was going to try something new, a temporary procedure. And miraculously, it saved his life. For which I am overwhelmingly indebted to the profession of medicine. And that procedure has now become standard. Because of that, my father's life saved. It gave me a life's mission. 18 years later, I became a surgeon fulfilling my potential as a devoted son, and later to be a father and a grandfather. So it's made me not just a better physician, it's made me a better person. That journey. And I'm humbled and honored for the privilege of addressing you as the president of the California Medical Association, because it has been a fulfillment of life's goal. To be the son of a disabled veteran of World War II, who was also an immigrant, and I grew up as a child farm laborer, so I know what it is to be without adequate health care. After a successful academic career as a transplant surgeon, being director at the Cleveland Clinic, at UCLA, and then subsequently at UCSF, I became an oncologic laparoscopic surgeon in private practice. And I've returned to my roots, working at a safety net hospital for farm laborers in Monterey Bay, the salad bowl of America, as it's affectionately known as. And most of my patients are farm laborers. Most speak, 95% speak no English. Many have inadequate medical coverage, and my presidency has been dedicated giving these patients and millions of Californians like them a voice. Now, CMA is a voice for our physicians and their patients, but in this past year, we have boldly changed the way healthcare is delivered, not just for this crisis, but forever. So we know that to best serve patients, healthcare must be physician-led, and I thank you all for here listening in your leadership in this, and most importantly, in this most important public health issue. So thank you for letting me share my story.
Thank you so much. So Dr. Wong, finally to you. You started out as a family physician and also worked in the safety net community health center, but also did some government public service at the Health Resources and Services Administration. Talk about your journey, please.
Well, first off, I have to tell you how honored I feel just to hear the stories of Dr. Maybank and Dr. Bretan. And it really reassures me that we have the kind of leadership that this profession has actually been starving for decades. It really heartens me that we have such really sincere leaders. And you can tell in their life journey that this is just not a speech that's made at the podium, but something that really is about their presence and their personal commitment and their family history. So I'm just so humbled by hearing their stories. My story, I don't want to belabor it too much because, we all go through different chapters, but I will say this. I was influenced as a kid, just liking science, but also the Marcus Welby story, which those of you who are little young don't know, famous television doctor who really took care of families and really got involved with the conditions beyond just the medical situation. That's TV drama. But one thing that I found out pretty early as I was pursuing studies in ethnic studies at UC Berkeley, of all things, was really just looking around in our communities and looking in Chinatown and seeing what are the Marcus Welby stories in Chinatown. And it is not the story that I saw, that was depicted on television. It was about slums, about people that didn't know where to get care, or if they got care, the practitioners were very stretched out. There weren't as many resources for the mainstream community. Chinese hospital in San Francisco was started 120 years ago because there was basically an apartheid system in San Francisco, not allowing Chinese to be seen anywhere outside of Chinatown. And that was part of the legacy. And at that point, I recognized that whatever I do in medicine is really about reckoning with that history and seeing what I could do as a son of Chinese immigrants who spoke some Toisanese and spoke some Cantonese and really had kind of a very central core of wanting to serve, that I would try to find ways to serve.
Great, thank you so much. And thank you, the three of you. This is perhaps not the way that every panel starts, but I think as we heard in those stories and journeys, how important it is to ground who we are and how we approach these issues. So let me turn back to Dr. Maybank first, but really invite additional conversation from everyone around this. So medicine is not immune from the other institutions in our society of having a history and legacy of racism, of discrimination, of exclusion. Dr. Wong just referred to Chinese hospital. Many people don't know that it wasn't until Medicare in 1965 that hospitals were finally desegregated in the United States. And so that's certainly within most of our lifetimes that explicit racial discrimination was actually sanctioned up until 1965. But within medicine and organized medicine, again, there has been the similar exclusion of Black and other physicians of color from the AMA, and the AMA has come a long way in acknowledging that history and beginning to redress that. So Dr. Maybank, do you want to talk a little bit about those efforts way back in 2008, but all the way up to the present day?
Yes, and thanks for the question. And Dr. Wong, I like the term of reckoning, and I think, that's really critical for medicine to engage in. I think there is a lot that has probably happened that has been made invisible over years and years and years that we just don't know about. But what we do know, because of records that have been kept, and many folks may know some of the history of AMA and their racist past, is that they did exclude pretty directly and intentionally Black physicians in different medical societies across the country. But there are also other, harms that were caused. We look at the Flexner Report of 1910, that was to, really speak about, getting rigor into medical education. And I'm sure there's some aspect that absolutely happened, right? Really got medical education to focus on basic and clinical science. However, and I don't want to say an unintended consequence, I think probably some level of some intention behind it, that 5 of the 7 Black med schools were closed as a result of that report. And that has tremendous impact even to this day in terms of the lack of diversity as it relates to having Black physicians within med schools. Now, even though they're not explicit policies as it relates to other races and Latinx folks or Native American folks, however, I have heard stories of exclusion at the state level And we just haven't quite unearthed all of that yet at this point. But in 2008, the AMA, and this was around the time, if we think about it, of the Obama presidency, it was a time when Ron Davis was president as well of the AMA. At that point in time, AMA actually started to dig a little bit more and started to do more things explicitly around anti-racism work. They were working jointly with the National Medical Association and had issued several papers to really unearth and name the history that had existed as it related to exclusion, and naming the individuals engaged and involved. And so as a result of those efforts, and there was another effort called the Commission To End Disparities, which some people are still very familiar with because that was around not too long ago, not around any longer. But there was an intention then in 2008, as a result of doing this work and investigation, that AMA needed to do an apology very directly and explicitly to NMA at their conference. And Ron Davis was president at that time, really calling out the importance of righting the wrongs of the past, and explicitly really talking about, though, the exclusion of Black physicians. So what we've done, at this point in time, and there have been, policies that have been put forward that have definitely advanced equity over the last, I would say, 5 to 10 years. Whether it's LGBTQ equity, race and ethnicity equity, gender equity more broadly, things around gun violence have definitely been coming and trickling forward. In 2018, there was policy that was passed specifically for the AMA to have a Center for Health Equity. And that's where I come in play, and my team, who I know is also watching in on this conference today, or this webinar today, also came into play. We need to have an organizational unit that was going to focus on embedding equity across the entire AMA. And so we're actually in the process of getting ready to release our strategic plan. We're now 2 years old. I can't believe that. COVID kind of took that year away from us in one sense, but also it created lots of exposure. But within our strategic plan, in addition to talking about embedding equity, one of our strategic approaches is about righting the wrongs of the past and of AMA's past and harms. And so as I've mentioned, it started with the apology, but it continues on. And so more recently, our CEO, Jim Madera, and the board all agreed to remove the name of Nathan Davis, who is considered the father of AMA, from an award, as well as remove a bust of him and a kind of an exhibit of him that's on one of the floors in the AMA. And this is really, folks ask me, did you convince them to do that? And I said, absolutely not. This has been Jim Madera, from my perspective, from a leadership level. You need to have leadership really accountable to doing this work. Really step forward. He read those articles himself that were published, and he took it upon himself. As soon as he read it, he sent the message, and he said that needed to come right down, and it needed to go into the archives and to become more of an educational point on that particular floor. So those are the things that we're starting to do. And within the report, just, and it's not just Black individuals and women that we've been able to identify some of the harm. Actually, in 1901, JAMA published an article supporting the Chinese Exclusion Act. And many folks don't know that, the rationale being, we have to protect ourselves, that this is a Christian country, and we don't want to regard them because they're heathen. And so I think that there are many areas of reckoning of what we're going to need to do over these next couple of years and beyond.
Great, and that's a perfect segue to Dr. Bretan, who in California we now see as sort of this beacon of progressive politics and inclusion, but California is also the place where the Chinese Exclusion Act was created, and there's been a long legacy of discrimination and exclusion, particularly against Asians, but also as you're now working with farm workers from Mexico and other parts of Central and South America, a long history of exclusion and discrimination against the Latinx population as well, in addition to the overall discrimination that continues of Black Californians as well, and Native Californians. So talk a little bit about where you see this conversation is going in California, and what the role of CMA as organized medicine's voice in it.
Well, my answer to the questions today's topic is the answer is absolutely. So let me share with you what CMA is doing in this space. Just recently, Justice, Equity, Diversity, and Inclusion, or what we affectionately refer to as JEDI, is now woven into the work that we do in CMA. We have a newly permanent JEDI standing committee, and we amended our articles of incorporation to include health, equity, and justice as a core CMA value. That just happened at the last Board of Trustees meeting. The JEDI committee works with our executive committee, which I oversee, to build out a strategy for sustained and meaningful involvement with everything that's going around in California. For the past 3 years, I have overseen the executive committee as the president-elect, and now as the CMA's, and it's probably because of COVID, CMA's first two-term president for many different reasons. And my focus, as you have heard, is to decrease healthcare disparities. And let me just share with you some of the examples. We had talked before the meeting about the workforce pipeline for our future physicians in California, by loan forgiveness to recruit new physicians who are here in California or to come to California and serve our greatly needed Medicaid, or what we call in California Medi-Cal, in rural areas. We really need some help there. As you know, Medicaid does not pay very much, and we require that they serve at least 30% of their practices dedicated to Medicaid or Medi-Cal via our CMA-sponsored tobacco tax. CMA sponsored that, and it raised $2.1 billion for that purpose. So that is going to ensure our pipeline. People like me, we have drank the Kool-Aid. You know, I'm going to go back no matter what. When we have data that show that if you grow up somewhere and you're a person of color, you're going to go back. We have a lot of physician legislators that that have done the same. So I'm just a point person in that. We have physicians that come back, and we know that we concentrate on them. Let me give you another example. I'm past president of the Philippine Medical Society in Northern California. Filipinx MDs have the highest Medicaid load in California. What's that tell you? That tells you that culturally we understand where they came from. I understand where my parents came from, and I know I owe this society much because I am enjoying the top aspects of society. So I fought, and that's going on not just with people of color. The whole CMA is obviously diverse, but we are fighting for telemed, and not just telemed, telephonic coverage, because many people of color, especially if you're working out in the field, they don't have any Wi-Fi. So I need to bridge that with telephonic. We're fighting to make that permanent. Just because of the vaccine rollout, and vaccine rollout across the country is difficult, but our EC speaks with the governor or Secretary of Health and Human Services, Dr. Mark Galley, about preventing disparities next month when they roll out more vaccines. We want to make sure that we remove the obstacles that will create the disparities. We could see this coming a million miles away. We focus on the underserved low-income patients of colors to get vaccinated by removing obstacles, by flexible vaccine tiers. You know, the other day they had an attestation sheet that they wanted us to fill out. Well, come on. You're going to call a doctor when you're inoculating 80,000 people. I mean, that's a huge bottleneck. We fought that, and you know, you just have to remove some of these obstacles because it's going to hurt the people that are underserved, not just people of color. we also have a healthy place index that shows those who have the highest risk of COVID. And you could overlay that where people are getting vaccinated. There is no overlap. That is bad news, because that just tells us that we're not vaccinating those with the highest risk of transmitting the disease. We're rapidly vaccinating people who have the lowest risk. So we have to fix that, and CMA has this health places index overlaid, and we are fighting to get the vaccines to the providers in this area. We have that data. The state doesn't have that data, and we are working just like, we distributed 80 million pieces of PPEs for California, so we hope to do that the same with vaccinating. So you probably heard in California that we have a third party administrator with Blue Shield. Well, insurance companies are used to being gatekeepers. Well, that culture has to stop, and they should be working with the CMA as distributors. So that's something that we can work with. We are vigilant and monitoring potential disparities. We are here to prevent bottlenecks. We are here to oversee the whole thing so that those who need to be vaccinated are going to be. Now, just to share with you, it's not a popular subject, but the prisoners are high risk. Yet we have 40% vaccination rate, and that's good. That's a good culture in California that they got the prisoners to be vaccinated, or else a lot of people would die. Hopefully I can give you news next month that we have those areas of health places index that are poorly served that are going to be brought up in terms of vaccination rate. But that's what CMA, organized medicine, can do. Remove obstacles, monitor, get things where they need to be. And that's basically community providers.
So thank you so much for sharing some of those organizational changes, but then also quickly, you gave us illustrations of in the policy advocacy that organized medicine does, which is so important on something like telehealth policy and reimbursement, but then now also in the day-to-day operations and practice of vaccine distribution. So Dr. Wong, oftentimes Asian Americans are viewed as the model minority, that we don't speak up, that these are not issues that we speak to. Obviously the horrific killings in Atlanta last week has really elevated the voice of a lot of Asian Americans. So talk a little bit about what you see as the voice of Asian American, Native Hawaiian, and Pacific Islanders in particular on raising issues of racism and how to confront racism as an issue.
Thanks, Ignace. I think there are a lot of areas and issues that are relevant to my answer. I think one of the things that we need to do as Asian American, Native Hawaiian, and Pacific Islander physicians is the fact that we contain stories. And I think Dr. Bretan was touching upon that. We need to tell the stories of what we see in day-to-day clinical practice. And the fact is, and I think Dr. Bretan mentioned the disproportionate death rates of Filipino nurses in the profession. 30% of the deaths of nurses in California are of Filipino descent. Now, I don't think anybody in the national media has reported on that. And we don't report on the stories around the Pacific Islanders representing, in some communities, the single highest death rate of any ethnic population. So these are things that we as Asian American, Native Hawaiian, Pacific Islander physicians need to amplify. We need to put out the story. This is really happening. And for us to be able to bring our credibility as physicians, as nurse practitioners, as PAs to the forefront, that this is documented and the data needs to tell our story. I think that's a really critical feature. I think the other aspect is relative to COVID-19, but also in terms of all aspects of clinical care, is how many of our populations that are linguistically isolated, culturally not provided the appropriate care, and geographically kind of challenged, whether it be in terms of the internet or because of transportation, that these are aspects of being good clinicians for our communities that we face barriers in every day. And contrast to this whole narrative that says Asian Americans have made it, we all drive nice cars and we're in the tech industry. That has been a total disservice to what's really happening across the diverse communities that make up the Asian American, Native Hawaiian, and Pacific Islander diaspora. There are so many, in California, we know that there's so many disparate groups of Hmong descent, of Khmer descent, of Bangladeshi descent. And the irony is, a lot of the physicians that make up our workforce are actually of those particular nationalities' descent. And they have not been given the opportunity to really amplify on these stories. So I think that's a critical feature of what we need to tell. And of course, Ignatius and I have been working at NCAPIP to bring forward these facts to national attention. 222 national leaders of API Native Hawaiian descent signed a statement that was circulated over the course of 2 weeks. We signed it, put it out for dissemination just in this last week. We hope to bring that to real attention at the national scale so that our needs are really integrated into COVID-19 strategy.
Great, thank you so much. So there's a lot of questions in the chat around how to build trust with communities, especially given some of this legacy of discrimination and racism and exclusion. And I also am hearing a theme of leadership. Dr. Maybank referred to Dr. Madara and the importance of that kind of leadership voice. And Dr. Bretan is now that voice for organized medicine in California. So in our few minutes remaining, what message do you have for physicians in the community to elevate their leadership so that that trust can be developed more with communities that they serve? Dr. Bretan, you mentioned you go back to the communities that you came from, and that's so important. And that's going to be so important around vaccine distribution and vaccine hesitancy, to have physicians visibly establishing that kind of trust and overcoming that hesitancy. So let me start with Dr. Wong this time and talk a little bit. How do we establish that trust with communities? How do we exercise our leadership as physicians?
Well, and I'm going to keep my answer short because I really want to hear from Peter and Aletha. But I will say this: it's not about rediscovering fire. In other words, communities and many community-based organizations, many qualified FQHCs, community health centers, have effectively been building trust in their communities because they come from these communities. And our private practices in small little Saigons or Koreatowns, they demonstrate that they have a following. Now, the question is, how do you spread and how do you sustain and how you build capacity for those community-based practices and community-based experiences to become much more the norm as opposed to the exception? And I think that that's really a goalpost that we should have for almost every community. I wouldn't confine that to the Asian American, Native Hawaiian, Pacific Islander community. It applies to the LGBTQ community. It applies to the disabled community. It applies to the homeless community. It applies to prisoners and incarcerated. We have to go to where the lessons have already been established and validate their significance and their contribution to creating new strategies. One thing organized medicine does is that we listen to ourselves as an echo chamber, but we don't listen to really what's been happening outside of the profession.
Great, thank you, Dr. Bretan.
Well, I agree 100% with what you said in terms of you have to build it around trust. I notice that when I take care of prisoners who are mostly minorities and Blacks, they love me seeing them. There's a lot of trust that goes with that you're just, you seem like you're a smart physician, but you're also culturally diverse. The extended culture lends to itself understanding. Same with my Hispanic patients. I speak Spanish, but there's something deeper that there's a trust going on. And that's important with hesitancy. Now, that applies to everybody across the board. You don't have to be a minority to build trust with your patients. You do have to have a doctor-patient relationship. And that is why CMA is trying hard to send the drugs or the vaccines over to the community providers who already have a relationship. I always say the doctor-patient relationship is sacrosanct, because once you have that, then it's a doctor and a patient relationship. You start with that. And you amplify that, because then there is no hesitancy. You have a doctor telling you what, I have patients that I've seen for 20, 30 years. They don't question a lot of things that we do. We have a dance that we do, and I'm always challenging them and they're always challenging me, but there's a deep down trust and relationship. I think the profession of medicine needs to monopolize what there is in no other profession. That deep-seated doctor-patient relationship is so emboldening, and there is a deep trust that comes with that. No other profession has that.
Great. Dr. Maybank?
Sorry, need to unmute. So I'm going to start first and just, I think what's also critical, I think, for organized medicine, and this has played out over the last couple of weeks, and really across race and ethnicity and across groups that have been marginalized, is always kind of keeping our eye on like the root cause and the challenges of white supremacy, and really this hierarchy of human value based on skin color, with white being on top. And that we have to always be, I think, very conscious of how oftentimes we can be set up to not work together and work in solidarity. And I think these moments really highlight, and I think these moments have been highlighted for generations, but especially now, the opportunity for us to work in greater solidarity within the context of organized medicine, to help advocate for changes, whether it's within our institutions as organized medicine or advocate for policy at the state and federal level. And we saw some of that, together. Dr. Wong and I are on emails together, in which the president of the National Medical Association, Leon McDougall, reaching out to folks, saying, hey, let's do a joint letter. And all of that, to me, is really important and critical at this time. And to make sure that we're creating spaces of belonging and not othering, I think is absolutely critical, just in terms of a value of how we go about doing this and working together. I also want to just speak to kind of something that Dr. Bretan just made. And, I realize I work for a physician organization. I am a physician. I highly value physician leadership, but I also have a very strong public health context. And I very much believe in the value and the power of other healthcare workers, and us working in partnership with other types of healthcare workers who also understand and are very intimately engaged and trusted by our community residents, where physicians may not be at the same time. And so I think about, today was launched by the federal office, the White House, over $300 million to help support community health workers, and the expansion of community health workers across this country to be able to work in partnership, I think, with healthcare providers and physicians to help support vaccine equity. I do think we need to value that in addition to our power as physicians and our voice as physicians, but also to really understand and recognize the collective opportunity that we have and we need to care for our patients. And then thirdly, while we are focused on kind of the downstream opportunities as it relates to trust, the foundational opportunity as it relates to trust and getting folks vaccinated, we still need to keep our eye again on the prize of the structural solutions that create these downstream conditions of the lack of trustworthiness, of harm, and all of these things. And so again, it's how do we create that balance? And I think organized medicine, really has that opportunity to kind of work across this spectrum of solutions to make sure that we have really meaningful change and lasting change, really.
Great, thanks so much for highlighting those points. And we're coming to the close, but I just wanted to note that there were some questions raised around data, which is a perennial issue, particularly for Asian American, Native Hawaiian and Pacific Islander communities, and especially the disaggregation of data, calling out the disproportionate death rate among Filipino nurses. I think we wouldn't know that if we didn't collect the disaggregated data. So that may be a topic for future conversations. Again, it's a perennial topic for our communities. But also a really important question raised about sort of educational resources and how physicians can reach out, not just in a leadership capacity, but to their peers in their organizations to do work around anti-racism, to elevate these kinds of issues. And I think that's a topic we may have some additional conversation about in the future. But let me thank our guests for the great conversation and for their journeys, and we look forward to collaborating and working with all of you. And Dr. Wong, do you want to close this out with some last words?
Well, certainly I want to thank Dr. Maybank and Dr. Bretan, not only for the webinar, but obviously for their leadership, as I mentioned at the very beginning. I have to acknowledge that the American Medical Association and Dr. Maybank specifically has really reached out to the minority medical associations that comprise the Alliance of Multicultural Physicians. And this has been an important step forward. And I think it's not only the recognition that we need to support these groups, but also recognize that they're independent and they have a journey themselves for their specific communities. So I think it's been a very healthy one and a very rewarding one. And Dr. Bretan, I have to recognize that the 55,000 physicians that make up the California Medical Association, they have a great challenge in front of them in terms of all the pressures of maintaining a viable practice and meeting the needs of Californians. These are really complex issues, but I think you touched upon a lot of the issues with regards to not only quality and access, but also with regards to payment structures and also social systems that create barriers for people to access care. So thank you for your leadership in that regard. So on behalf of NCAPIP, thank you audience for joining us. We want this to be ongoing dialogue. Certainly email us. This will be recorded and give us some suggestions for the next conversations with NCAPIP. And thank you, Ignatius, for your great moderation. And thank you, David Hawks, for being in the backdrop, helping us with the technological issues. Good night, everybody.